Yes. Look at the just I'm reading the uh, surgical indication of severe chronic mitral valve regurgitation, and you will tell the like what we'll do. Okay, now in primary MR, not in secondary MR. In secondary MR, it is medical management. Valve surgery is not needed. But in case of primary MR, surgery, if left ventricular ejection fraction is 30 to 60%, regardless of symptom. Okay. Consider surgery. If successful valve repair is highly likely, asymptomatic left ventricular ejection fraction is more than 60%, and symptomatic and left ventricular ejection fraction is less than 60%. Okay, now you tell me what does it mean actually? Yes, secondary it's only the medical management. So it's primary MR. They are not talking about other secondary causes, so looks like we need to do the valve repair. Yes. Look at the CT scan. Looks like dissection, isn't it? So it's a surgery. Yes. Yes, it's AFib. Wait, atrial atrial fibrillation has multiple causes. So, atri yes, you say. Okay, so this patient, just read from this young patient, like in the middle, this young patient with no known risk factor, and her echocardiogram show non-valvular disease and left ventricular dysfunction that may be contributing. The best next step is to check serum TSH level to evaluate for hyperthyroidism, which can increase atrial conduction automaticity and is a potential trigger of atrial fibrillation. In some cases, atrial fibrillation may be only apparent. Atrial fibrillation may be the only apparent clinical manifestation of hyperthyroidism, but hyperthyroidism is readily treatable, and treatment commonly leads to resolution of the atrial fibrillation. So serum TSH and free T4 level should be checked in all patients with new onset atrial fibrillation. That's the trick. So even if no symptom is present, but as it is a new onset atrial fibrillation, go for TSH and rule out the hyperthyroidism. Yes, it's wait. When you will see the ECG, first you will see the P wave, then then PR interval, then QRS complex. Look at the P wave. Yes, okay. Now count the PR interval. Normal is 3 to 5. Okay, next. Yes, it is more prolonged and no. Oh, yes, yes, yes. It's Mobius type. Yes, yes. Sorry. So progressive prolongation of the PR interval, then a beat is dropped. Wait, okay. It's you see the ECG again. Okay. No, it's not Mobius type 1. Okay, you are on the track, like you are on the track. Okay, now count the atrial rate and the ventricular rate, because why I have said so, like Mobius type 1 is progressive prolongation of the PR interval, then a beat is dropped, but the very fourth part of the, look at the fourth portion, fourth or fifth part of the ECG. uh, yes, so in here there is PR interval, PR prolonged, but before that, this one, this one, like the before the next before one. Okay, I am sharing my screen. Okay, now can you see my screen now? Okay, look at this part. This part. Uh, in here, PR is not prolonged. Got it? But so in here, P wave is not following the QRS complex. The pattern is not following the QRS complex. And again, another thing, if we count the rate, like 300, 150, 100, 75, 60, 50, so there is bradycardia. Okay, and if we count the atrial rate, like from this point to this point, it is atrial rate, and this point is the ventricular rate. If you count the atrial rate, like 1, 2, 3, 4, 5, 6, 6.5, like 300 divided by 6.5. If you calculate what is the result? 6 and 6.5. Yes. Okay. Okay. 46.1. Now the ventricular rate. 1, 2, 3, 4, 5, 6. Now, more than 6, like 7, closer to 7. So 300 divided by 7. So 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 atrial rate is more than the ventricular rate. So if atrial rate is more than the ventricular rate and P wave is not following the QRS complex, that means P wave not discernible with the QRS complex, and atrial rate is the more than the ventricular rate. So it's looked like third degree heart block. Complete heart block is tough. Look at the answer. P wave and QRS complex dissociation. That means you haven't shared the screen. Yes. When there is P wave, then the QRS complex. P wave, then the QRS complex. But in here, P wave QRS complex dissociation. That means P wave is not following the QRS complex. P is equal, QRS is equal. You are thinking this. There is PR prolongation thing, but there is another criteria like atrial rate is more than the ventricular rate. I don't know they have calculated this. Yes. So uh, if you know this is hard block, then you can do it. Like you can do permutation combination. But if you don't assess that it is hard block, then it will be very hard. Yes. Okay, so it is compartment syndrome. The patient who underwent femoral embolectomy, now has tense swelling on the right cuff, paresthesia, burning sensation, severe pain is severe pain that is worsened with passive range of motion and sensory and motor deficits. This presentation is most consistent with compartment syndrome, a life-threatening condition that is caused life-threatening condition caused by increased pressure within the enclosed fascial space that limits perfusion of the muscle and the nerves. It is most common following traumatic injury. Long bone fracture, or prolonged compression of an extremity, but it may also occur following reperfusion of an acutely ischemic limb ischemia reperfusion injury due to interstitial edema and possibly intercellular swelling. Diagnosis can be confirmed by measuring compartment pressure, needle manometry, a delta pressure, diastolic pressure minus compartment pressure less than 30 indicates inadequate tissue perfusion and is strongly suggestive of compartment syndrome. It is typically more useful than absolute compartment syndrome because diastolic pressure can vary significantly. Systematic hypotension. Definitive management includes emergency fasciotomy. Okay. Okay. So this patient's presentation is suggestive of right heart failure, more, most likely due to constrictive pericarditis. Right heart failure, most likely due to constrictive pericarditis, a potential late complication of radiation therapy. Survivors of Hodgkin lymphoma are increased risk of cardiac disease, which can present 10 to 20 years or more after mediastinal irradiation and anthracycline therapy. Potential cardiac complications of the Hodgkin lymphoma include acute or delayed pericardial disease, accelerated coronary atherosclerosis, restrictive cardiac myopathy, heart failure, valvular abnormality, and conduction defect. Constrictive pericarditis occurs as a result of scarring and subsequent loss of normal elasticity of the pericardial sac. The inelastic pericardium restricts venous return to the right side of the heart, leading to right-sided heart failure. Patients typically have peripheral edema, ascites, and hepatic congestion with hepatomegaly, which can progress to cirrhosis. Physical examination typically shows elevated jugular venous pressure with hepatojugular reflux, whose mole sign paradoxically increase mm, in JBP on inspiration, and pericardial knock, early diastolic sound. Patients may have pericardial effusion calcification on chest imaging. Echocardiography confirms the diagnosis typically. Shows increased pericardial diagnostic typically shows increased pericardial thickness and abnormal septal motion and biatrial enlargement. Diagnosis can provide temporary relief, but pericardiectomy is the definitive treatment for patients with refractory symptoms. Got it? Okay. So this patient who has a brief really loss of, or this patient who has brief loss of consciousness shortly after standing from wrestling, or shortly after standing from wrestling mat, most likely experience syncope due to orthostatic hypotension. Orthostatic hypotension occurs when blood pressure is significantly reduced on standing. Blood pressure is significantly reduced on standing, typically due to hypovolemia or an impaired baroreceptor mediated response autonomic dysfunction. In this patient, the most likely cause is hypovolemia due to fluid restriction and diuretic use, a method used by some athletes in combat, a method used by some athletes in combat sports like wrestling or boxing to achieve rapid weight loss and a competitive rapid weight loss and compete in a lighter weight category. Evidence in this patient include hemoconcentration, hemoconcentration, elevated blood urea nitrogen, elevated blood urea nitrogen or creatinine ratio, hypokalemia from diuretic induced potassium elimination. So that's why potassium is low. Okay. The standing normally causes rapid drop in blood pressure. The standing normally causes rapid drop in blood pressure due to venous pooling in the lower extremity, triggering baroreceptor mediated increase in sympathetic drive with peripheral vasoconstriction to mobilize from the legs, as well as increase heart rate and contractility to increase cardiac output. In euvolemic patients, sufficient intravascular volume allows an intact baroreceptor mediated response to maintain adequate cardiac preload, cardiac output, and cerebral perfusion. However, inadequate intravascular volume prevents maintenance of cerebral perfusion, sometimes resulting in syncope. Got it? In like in conversion disorder, it can present with loss of consciousness, but in conversion disorder, there is a prolonged unresponsive period. Like the conversion disorder patient, they they are like, think about a syncope, like just 1 to 2 minute fall down, then he again got up, and they are not like too much what can I say, they are not waiting like conversion disorder patient, they are more conscious that they are faking. That's why they actually fall down for unresponsive for prolonged period. Like syncope can occur 1 to 2 minutes, then the patient become awake for after 1 to 2 minutes. They will not gonna fake for long time because they are actually sick, so they do not know why it happened, but the conversion disorder patient knows why they are doing, that's why they are taking too much time. So if you calculate the time, then you can make the diagnosis. And in conversion disorder patient, they cannot do the electrolyte abnormality, like this patient has actually low potassium is 3.1. It is not possible for a patient in conversion, they can uh, do the they can not make the potassium instability. Got it? Yes. Okay, it's extra hard sound. Like this one is S3 gallop. This is the gallop breathing. S3 gallop. Yes, I I am trying to. I try to hear more and more to find out this. And they are because you cannot look, look at the stem. You thought mitral area. The in mitral area there is mitral stenosis or regurgitation, but is it the answer? There is the answer is MR. You may think that the answer is MR, but uh, it is very tough. You have to remember the S3 gallop, then you can calculate this. Okay. Okay, so there is nothing to read here. Okay, just remember the cause of the S3 and the S4 because you have found that it might be either MS or MR. So it's MR. Okay. Look at the cause of the S3. That's why I told you to remember the cause. Like heart failure with reduced ejection fraction. S3 has associated disorder like heart failure with reduced ejection fraction, high output failure like thyrotoxicosis or AV fistula or MR or AR. And S4 is a CAR like constrictive left ventricular hypertrophy, acute MI, and restrictive cardiomyopathy. S4, the CAR. That's right. Okay. These patients sudden brief 1 to 2 minute episodes of these patients sudden brief episodes sudden brief episode of loss of consciousness and postural tone followed by rapid recovery is consistent with syncope. Syncope occurs due to global hyperperfusion of the brain. Can have any can have many causes. In most cases, syncope is benign and self-limiting. However, it can be initial manifestation of life-threatening diseases, life-threatening disease process, cardiac syncope. A detailed initial evaluation can provide several clues of underlying etiology. And these patients' syncopal episode had no obvious trigger or prodrome to implicate reflex syncope. It also did not occur with position changes, standing from a seated position to suggest orthostatic syncope. Instead of the syncopal episode occurred with the patient at rest and without warning symptoms. This presentation raises concern for cardiac etiology, specifically arrhythmic etiology, should prompt further evaluation. Continuous ECG monitoring can evaluate for transient arrhythmia, ventricular tachycardia that may not be detected on initial ECG. In relatively young patient age less than 40 without structural disease, ambulatory ECG monitoring, Holter monitor, insertable cardiac monitor is usually appropriate. In contrast, patients likely need hospitalization for closer monitoring and expedited cardiac evaluation when they are older and have any structural heart disease, prior myocardial infarction, or have an abnormal ECG. Got it? Yes, sensory neural hearing loss. Is it Romano-Ward syndrome, this kind of symptom? Congenital deafness, Jarvel-Nielsen and Romano-Ward syndrome, congenital long QT syndrome. This patient, oh, so it's Long QT is 450 to 550 milliseconds. I am prolonged QT. Wait. T wave. Normal QT interval is 450 millisecond. 415. That means looks like uh, maybe long. Sorry, is it beta blocker? I am not. Amiodarone, ibutylite, dofetilide, sotalol. These are class 3 antiarrhythmic. Amiodarone, ibutylite, dofetilide, and sotalol. AIDS. It cannot be happen. And ethosuximide for absence seizure. And levetiracetam again for either it is propanol or quinidine. It is long QT. So I have telling you about 450 millisecond. 450 to 500 I have told, but it is if it is more than 460, then it is long QT. Look at the ECG 520. So you have to calculate this like from Q to the T. From the onset of Q wave, the end of the T wave. It is the long QT. And one small square is 40 milliseconds. So 2 and 5 are 10, 12, 12, 13, 14. 14 into 4. 14 into 40. 14 into 40. Sorry. 14 into 40. So 560. Okay, got it. What I have done, okay, I am making you understand. It's not that tough. Uh, okay, look at this. Just try to calculate. Wha- Okay, so from okay, I am talking about the long QT, isn't it? Look at the first how I assess that it may be long QT. Why I assess? Because the T wave is not in the normal pattern. T wave is very like they are swimming in the ocean like of pattern. Look at this. Uh, think about a lady. Okay, sorry. Think about somebody who is swimming for uh, who is swimming unconsciously like that. Okay, now if the t interval, if the t wave is just like that, think about long qt. Okay, now need the calculation part. The onset of this is the q wave. The first negative deflection is the q wave. This is the q wave. So the start point of the q wave and the end point of the t wave is the qt interval. Now you need to calculate the small square. So I have told you one small square is 40 millisecond. So 1, and in big small square there is 5, 5, 5, 10, 11, 12, 13. So if we calculate 13 into 40, uh, it is 520. Got it? Yes. Each small square is 40 millisecond, and 40 into 5, that means large square is 200 millisecond. This large square is 200. So 40 into 5, that means 200. Got it? More than 450, that means more than 460, that is long QT. So if you find out it is long QT, then you can correct this answer. Got it? Am I making you uh, okay? No. Am I explaining too much? No, no. ECG, ECG, and again, I will give like, okay, just stop here and I will show you something. Okay, we can do the uh, rest of the 10 question later. Okay, okay.